The title of this presentation is Locus Minoris Resistentiae, 2 Cases of Malignant Metastasis. I would like to thank all of the authors who contributed to this case report and presentation. None of the authors have anything to disclose. Introduction. Locus Minoris Resistentiae in Latin means a place of less resistance. From a medical standpoint, locus minoris refers to a decreased resistance in any internal organ or external body region, leaving it more vulnerable to disease processes relative to other regions. This phenomenon was first reported by Chesney et al. At Johns Hopkins in 1928. They found that when rabbits with wounds on their backs are inoculated with either intratesticular or intravenous treponema, syphilitic lesions invariably developed in the wounds. Sager et al. In 1929 demonstrated that subcutaneous injections of silver nitrate in rabbits caused sterile abscesses, and after subsequent intravenous injections of streptococci, streptococcal organisms were later isolated from the previously sterile abscesses. This phenomenon occurs due to changes in the microenvironment secondary to previous trauma and results in increased vulnerability. As a result, infection, inflammatory processes, and even malignancy may localize to these areas. For example, a damaged heart valve can act as a locus minoris, a place where bacteria in the bloodstream tends to settle. Furthermore, psoriasis, systemic sarcoidosis, and systemic lupus erythematosus have been associated with localization to the site of a tattoo, both as the initial manifestation of the disease or accentuation of an existing disorder. Here we describe 2 cases of locus minoris. Case presentation number 1. A 64-year-old female with history of bilateral brachioplasty initially presented with abdominal pain, pelvic pain, ascites, and a left ovarian mass. She was diagnosed with stage 4A serous carcinoma of the ovary and underwent posterior exenteration, coloproctostomy, omentectomy, and left aortic node biopsy. She subsequently received adjuvant chemotherapy with carboplatin and paclitaxel, followed by maintenance bevacizumab for 1 year. She was then found to have an increasing CA-125 marker, and chemotherapy regimen was changed to liposomal doxorubicin and bevacizumab, after which the tumor marker normalized. The patient later developed an erythematous rash and nodules in the left axillary region overlying the site of prior brachioplasty, which is depicted in image 1. She was initially treated for presumed herpes zoster infection with acyclovir for 10 days without improvement. Subsequent biopsy later revealed malignant cells consistent with ovarian primary, and repeat CA-125 was again noted to be elevated. Case presentation number 2. A 59-year-old male with history of L4 to L5 vertebral fracture secondary to a fall 10 years prior presented for mild urinary symptoms. He was found to have an elevated PSA level, and prostate biopsy revealed malignant cells consistent with primary prostate carcinoma with a Gleason score of 8 and clinical stage 2. He was treated with primary radiation to the prostate gland and surrounding tissue. He remained stable for 4 years at which time PSA was again noted to be rising. PET scan demonstrated FDG avid uptake to the L4 to L5 vertebral region corresponding to the same location of the prior vertebral fracture, and MRI showed vertebral metastasis and a mass lesion at L4 to L5 vertebral body region with mild spinal cord impingement. Additional examples of locus minoris are demonstrated by images 2 through 4. Image 2 demonstrates metastasis at the insertion site of a percutaneous endoscopic gastrostomy tube in a patient with primary squamous cell carcinoma of the head and neck. A review of literature demonstrated 42 cases of isolated squamous cell metastasis at PEG tube insertion sites. Image number 3 is a bone scan of a patient demonstrating metastasis of squamous cell carcinoma of the lung exclusively to the right knee, which had been previously injured 6 weeks earlier. Image number 4 includes a CT abdomen demonstrating metastasis of squamous cell carcinoma of the lung exclusively to portions of the liver, denoted by the arrows, which had been injured in a mechanical fall 2 months prior. The relationship between locus minoris and malignancy may be underappreciated. Contrary to the previously accepted notion of metastasis being random cellular anarchy, the process of metastasis may not be entirely random, but rather selective. Figure 1 depicts the seed and soil hypothesis. The most commonly bone metastatic cancers are thyroid, lung, breast, renal, prostate, and multiple myeloma. The bone microenvironment can be viewed as the soil and contains multiple entities that impact cancer cell survival and establishment of bone lesions. The metastatic process involves primary tumor angiogenesis, local invasion and intravasation, dissemination via circulation, extravasation, and colonization of a metastatic site. Components of the bone microenvironment include endothelial cells, stromal cells, adipose cells, osteoclast, osteoblast T cells, B cells, and the chemical structure of the bone. Figure 2 depicts the metastatic cascade, as well as the genes associated with each step in the cascade. Figures 3 and 4 include schematic comparisons of wound and tumor microenvironments created by cells located in the granulation tissue and tumor stroma respectively. For example, Figure 4 demonstrates the presence of IL-8 in both the wound and tumor microenvironments. There are two distinct yet not mutually exclusive hypotheses for the mechanism behind the association between locus minoris and malignancy. Hypothesis 1 is that physical trauma induces tissue damage and local inflammation, creating a favorable environment that is permissive for seeding of metastatic cells from distant sites. This is demonstrated in Figure 5, where trauma and wound healing initiates the migration of macrophage with an M2 phenotype to the site of injury. The production of inflammatory mediators such as growth factors, angiogenic factors, and chemokines attracts tumor cells to the site of injury, therefore establishing metastasis. Hypothesis 2 is that micrometastatic foci, which are already present at the time of trauma, initiate changes in the microenvironment in response to an injury that stimulate proliferation of the metastatic cells. This is also demonstrated in Figure 5 as occult micrometastases are already present at the metastatic site, and after traumatic event, there is migration of M2 or TAM-like macrophages, which then release the aforementioned mediators, causing proliferation of already established metastatic focus. It is important to note that in some cancers, dormant micrometastasis has not occurred, and thus hypothesis 2 of the trauma-related metastasis is not plausible. Although some chemokines and growth factors that may be released during trauma or scar formation are pro-angiogenic, such as IL-8 and TGF-beta, others, such as IL-10, are anti-angiogenic. It is likely that a balance between pro-angiogenic and anti-angiogenic cytokines and chemokines is more important than the actual levels in tumor-associated angiogenesis. In conclusion, recognition of a locus minoris environment, especially in unusual sites of prior injury, has important implications for identifying potential metastatic disease processes and initiation of prompt interventions in order to prevent disease progression. The use of perioperative chemotherapy may also limit the emergence of any dormant malignant cells associated with surgical trauma associated inflammation, and finally, further exploration of post-traumatic surgical disruption inflammatory oncotaxis may elucidate fundamental mechanisms of metastasis and could provide novel strategies to prevent cancer metastasis. That concludes this presentation. Thank you very much for your attention.